go ahead and share my screen. Dr. Rexroad, I know you're driving in the car, but I'll still share screen and pull up your case. But yeah, I'll turn things over to you. Let me know if you need me to do anything on my end. Thank you.
Okay, am I unmuted?
Yes, ma'am, we can hear you.
Okay. I printed off the what you have on your end, I think, Mitra, so we should be good. The case is a 31-year-old white man who we hadn't seen in our practice for several years, but he came back several weeks ago complaining of abdominal pain. Knew he had HepC, had been treated in 2012. He didn't know with what, but we finally dug around and got his records actually at WVU. And he got interferon for a couple weeks, maybe a month or so, and then he went to jail and they couldn't figure out what to do with that, so he never got any more. He's turned himself around a bit now. He's got a responsible job. He wants to be healthier and would like to be treated if possible. He's quit smoking. He says he doesn't use any alcohol. He says he does occasionally use marijuana, and I'm not sure, I didn't necessarily put it on there, but that lorazepam and Suboxone that are on the med list may not be prescribed for him. He had gone to school through 8th grade, then he got a GED. He has anxiety, he has reflux. When he came to see us, his vitamin D level was low, so we started on the replacement. He started on the sertraline from us and the trazodone. He is immune to Hep A and B. You guys can see his BMI is a little elevated, 32.3. His labs actually, white blood cell counts fairly is normal. Platelets are normal, kidney function, sugar, all that. His LFTs are somewhat elevated. I don't really have another set to know whether there's a trajectory there or not. His inflammatory scores don't look all that bad. His genotype is 1A. Viral load is 5,910,000. And I guess the big question, I think I've got another partially treated person here, so what do I do with him? And unfortunately, because I'm on the phone, I don't have access to his chart, but if the hub members have questions, I can get the information back to Mitra within the next day or so.
Excellent. Thank you so much, Dr. Rexroad. That was a great case presentation from your car, so thank you. Any clarifying questions from the group before any recommendations? All right, and any feedback or recommendations for Dr. Rexroad? Dr. Gilfus, I see you unmuted there.
It's habit, sorry. I
love it.
It's always a challenge when people have this history of treatment in the past and are unsure. So just like a 2-second history lesson for the pre-DAA, so the pre-direct acting antiviral era, that can help your patient, because a lot of times people don't remember the names of the medications. And 2012 was tricky because there were quite a few medicines available. So the core was pegylated interferon given once a week. And then the key questions that are helpful to ask the patient is, did they take pills along with that? And did they take just a couple pills twice a day, or did they take a ridiculous number of pills 3 times a day, 3 to 5 times a day? So available from 2011. Now, honestly, it was more like 2012. So right when he started getting treated was boceprevir and telaprevir. These were the initial protease inhibitors, and they were TID drugs. These were 3 times a day drugs, somewhere between 2 to 3 tablets 3 times a day, plus ribavirin was always used, which was a BID drug. So literally the cocktail of medicines that people would be taking back then looked like a mid-1980s HIV regimen. They were very, very impressive. So if you ever can't find the records on somebody, just asking the question of if they took their medicines BID with their pills, or did they take an extra time a day, and was it just a couple pills, or was it a whole bunch of handfuls of pills? Because and that can help you differentiate. Now, honestly, I love your question in this one, Dr. Rexroad. Because the exposure had nothing to do with treatment failure, and this was just a little bit of exposure, I would not even count it at all. I would discount it completely and go ahead and treat the patient like they were not exposed. But just from a learning sake, if they had prior interferon exposure, it doesn't change much unless they're also cirrhotic. There's a wonderful, wonderful table on UpToDate. It's not as nice on hcbguidelines.org, but there's a beautiful table on UpToDate that I could forward to anyone interested, that sort of runs you through interferon exposure by genotype, and then interferon plus the old protease inhibitors, depending upon genotype, and cirrhosis or non-cirrhotic. So in other words, those are the variables involved. So what were the particular drugs? Were the protease inhibitors involved, et cetera, what's the genotype, and is there cirrhosis? For this one, he's non-cirrhotic. His exposure was negligible, and it doesn't sound like he probably took protease inhibitors. So really, your treatment options are the same as for anyone else. I love a feel-good story. This guy sounds like he got his life together. Good time to reward him, with Epclusa for 12, or Harvoni for, I guess it would be, he could actually get a short course, but rarely do we do Harvoni short course for Medicaid because of the coverage. And he could also do, Epclusa 12 or Maverick for 8. I wouldn't say that it would impact anything for him because his exposure is so finite, and probably didn't include the protease inhibitors. They were just getting on the market around 2012. They were approved summer of 11, but we didn't start using them until like sometime about 6 months after that. And they were terrible, by the way. They gave people rashes, and nobody took them because there was 10,000 pills a day, and so on and so forth.
Thank you so much, Dr. Gilfus. And if you have that up-to-date information and you want to email it to me, I'm happy to include it in the recap as well.
Absolutely. I'll send it in a PowerPoint form.
Oh, awesome. Thank you. Love your PowerPoints. Any other recommendations or feedback from the group?
As per usual, he would not need a long-term HCC screening. I didn't even mention that one because, you're going to treat him early. So no significant fibrosis. Sounds like a good time to get him treated, and hopefully that Suboxone does its job and he stays with no relapse.
We're hoping so.
It's fun for me to go down memory lane on those old protease inhibitors. I'm sure Dr. Feinberg remembers them too, but it was not fun days. The adherence was a challenge.
I see Dr. Feinberg agreeing. Please drive carefully, Dr. Feinberg, but I see you're agreeing, nodding in agreement. And unfortunately, I'm not able to unmute you. I can only click ask to unmute. So, oh, there we go.
Did it work?
Yes, it
Yeah.
did.
Yes, Dr. Gilfus is 1,000% correct. Telaprevir and boceprevir plus interferon was a nightmare for the patients and for us. Just terrible, although, it at least was a stepping stone to the current era, but those were not good drugs and they were really hard to tolerate.
Yeah, fortunately, their tenure was about 2 years, because then, 2014 came about, and then life got good.
Right. That's the other good thing about them. They weren't around for long.
Thank you both so much. And Dr. Rexroad, did you have any other questions or anything you wanted to discuss about this case further? I think you're muted now. Oh, there we go.
Okay, yeah, sorry, we're playing tag here with the mute buttons. No, I think, the main question was, do I have to view this as a treatment failure? And you answered that right off the bat, Dr. Gilfus. So that's what I needed. Thank you.
Awesome. We're happy it was taken care of, and I'll get you those recommendations after the session as well. All right, Gary, I will pull up your case now. Let me see. All right, and are you okay if we start with 2821?
Yeah, that's fine.
Awesome. All right, I'll turn things to you now.
So this is a 33-year-old female. She's new to me. She reports that she used to do IV drugs. She started when she was 19 and stopped at 25. She was clean for 5 years. She stated she was tested for hepatitis C during that time and she was negative. She started using IV heroin again at 30. She went to rehab and that's when they discovered she does have hepatitis C, and she's been clean for 3 months now. She was in the ER recently. She had a CT of the abdomen and it showed normal liver and spleen. She has a history of depression and anxiety. She's not on medications for that, but she is attending therapy and she's doing well with that. The only medications she's currently taking is nicotine gum and ferrous sulfate. She's not immune to hepatitis A, but she is immune to B, and we have started the hepatitis A series. Lab-wise, her ALT is a little bit elevated, 66, but the rest were pretty much okay. Her ferritin was a little bit low. She's on replacement. She's genotype 1A. Her fibrosis marker was F0. That's pretty much it. So I think this is a pretty straightforward case. So I'm assuming Maverick or Appaloosa is fine.
Awesome. Thanks so much, Gary. All right. Any clarifying questions for Gary in this case? All right. Oh, Rachel, I see you unmuted.
Yeah, I just wanted to see, is she on anything for birth control? Any contraceptives?
No.
Any other questions before we go into the recommendations? All righty, and any recommendations, feedback from the hub members?
Sure.
Dr. Gilfus?
Yeah, first I'll start with feedback. Gary, man, I love how you define the risk factor timeline. I just wanted to compliment you on how you do that, because that's exactly how my brain needs to think. When is the first possible exposure? When was the most recent exposure, and did they have any other prior testing? That's the best way for you to narrow down exactly how much of a head start this virus must have had. And you have very well, triangulated. This is very recent, incredibly recent in her, just a couple of years head start, not doing anything to her yet, no fibrosis. You're in a good spot. She's a rare bird that has no medicines and private insurance. And so, your treatment option could include a short course Harvoni. Remember, so the viral load less than 6 million and non-cirrhotic and stuff like that. And you can do 8 weeks of Harvoni, which is kind of cool because it's one pill once a day for 8 weeks. Your other option is Maverick for 8 weeks, 3 pills once a day, and then Appaloosa for 12, but all be fine. Zepatiers, some commercial insurances will want you to do that one. And remember, if that's the case, you got to do NS5A polymorphism testing to delineate the duration, because she's a genotype 1A. But otherwise, I agree with you, man. This is perfect patient to treat. You're gonna, get this behind her at a time period when she is of childbearing age. So this is really pertinent for Dr. Feinberg's talk today about pregnancy and HepC, because you'd love to get her treated before there's any potential for mother to child transmission. As Rachel was alluding, she's got to make sure she doesn't get pregnant. That's could be behavioral, could be with medications, something, just got to make sure that she doesn't get pregnant while she's taking these pills, because we don't know how safe it is. So, but that's it. That's all I have on that one. Great job.
Sounds good.
Thank you. Any other recommendations, feedback from the group? Great. And Gary, were there any other questions about this case before we go to your second one?
No.
All right, awesome. Thank you. Let me pull up your second case now. All righty, so I'll turn it to you again.
So this one is a little bit different. It's a 31-year-old male. He has a history of IV heroin use and smoking crack cocaine. His first use was approximately 12 years ago. He was clean for a few years and relapsed. He last used was 2 years ago. He does have a history of incarceration, but no tattoos. He was first diagnosed approximately 8 years ago, but he's not sure of when his first exposure was. So it could have been anywhere from the 12 years. He's been previously referred, but he was never treated by anybody. I have ordered an ultrasound since then. Well, it's been completed, should I say. The only thing, and the liver was fine. Pancreas was normal. The only thing it showed was gallbladder sludge, but no lesions on the liver and normal size. He is not immune to hepatitis A, but he is immune to hepatitis B. Oh, the one thing I wanted to point out. So we have a report in February of 2016 stating his HepC positive, genotype 1A. But his lab work from April of this year showed genotype 3. So I'm not sure if he cleared it and he got reinfected. Otherwise, the rest of his labs are pretty straightforward. He does have an elevated iron count. And like I said, his current genotype is 3, fibrosis marker is F0. And we have ordered the hepatitis A vaccine series. And he's on no medications. Sorry, I jumped around a bit, but I think that's everything.
No, no worries at all. That is totally fine. Okay, thank you so much, Gary. Any clarifying questions about this case? And anyone's welcome to chime in. All right, and any recommendations, feedback from the group? Dr. Gilfus, I see you unmuted there.
Hey, Gary, that's wild. I don't know why the genotype flip-flopped. Your theories are correct. You know, it could be a mixed genotype. I don't know why. I don't know. I really don't have a good answer for you. You know, the beautiful thing in 2022 is our pan-genotypic agents. It's a little less of a worry now. But this is, you know, I'm really glad you're catching your patient now. He's a genotype 3. And he already probably has a decade head start from the estimate of when his risk factors were. So he's certainly someone in the next 5 to 10 years could actually start laying down some significant fibrosis. I'm glad you're catching him when you are. Be a wonderful guy to treat. And as such, you should be good. I thank you for getting the ultrasound. That would have been the only recommendation I had had, is some form of liver imaging. Boy, I wish we all had elastography. I think that would be cool, just to grab one other modality to make sure, since he has had a decade of genotype 3. But I think you're okay. You know, all of those other numbers look very optimistic. Treatment options, Maverick for 8, Epclusa for 12. He is not cirrhotic, so you don't have to do your NS5A genotype testing ahead of time. So remember, for genotype 3s that are cirrhotic and treatment naive, you do need to do your NS5A testing. But in this scenario, you don't, because he's non-cirrhotic. So you're going to be good to go. It's a good time to treat him. And yeah, I like your patients without medicines. I'm jealous. That's awesome. And, you know, and I forgot to mention, I'm sorry, on the previous case, and I think Rachel was touching on this, if that lady does end up going to the prior case on some birth control medication and you use Maverick, remember, you got to use a progestin based, because of the estradiol interactions with the protease inhibitors. So that was just an aside from the previous case. But on this one, I don't worry about pregnancy because he's a man, and at least I don't think that's an issue. But yeah, let's get him treated. Great find and good time to hit him, and you should be good going forward.
Sounds good. Thank you.
Thanks, Dr. Gilfus. Any other comments from the hub members about recommendations, feedback? Rachel, I wasn't sure if you had any comments about drug interactions. I know Dr. Gilfus touched upon that, but.
Yep, not with this case.
Awesome, thank you. And Gary, any other questions or things you wanted to have addressed about this case?
No, I think they were all covered.
Awesome, thank you so much.
Thanks.
Really appreciate it. All right, let's see. Dr. Feinberg, I'm hoping we didn't lose her because now I'm taking a look at the Hollywood Squares and I don't see that she's on. So she may actually have lost connection because I know she was on the road here. So
Petra, if we have a few seconds, Brian's on. Hey, Brian, do you mind bringing us up to speed on those Medicaid changes? Because I saw you texted that into the chat and I haven't had a chance to look at them. So.
Sure, John. Priya Shah is our DUR coordinator. She's not on right now, but she created the criteria, but I could certainly go over it because I had requested a couple of these changes. And essentially the major changes are highlighted. And those are, we recommend, but no longer require a consult for what we term non-complicated patients. So patients that are 18 years of age or older, treatment naive, non-cirrhotic, HPV negative, HIV negative, non-pregnant. Those patients can see, nurse practitioner or anybody without requiring a consult to be documented. Although we do still recommend it. Specifically, we recommend it with ECHO or HAMP, West Virginia HAMP. And then we also we got rid of the sobriety requirement. Basically, we just ask the prescriber to, essentially we're encouraging the prescriber to make sure you're picking a good patient. So, these are still expensive. We certainly don't want to waste therapy. We've had a number of retreatments that are not due to failure of the drug, but due to failure of the patient. Most common that I've been made aware of are patients stopping taking their drug because they get nausea, and then they either don't contact their primary physician or they go to the ER. And if you go to the ER, the physician doesn't want to necessarily, I think, be responsible for an adverse effect. So they just say, stop taking it and call your doctor. And so we've had probably 5 or 6 of these now where, it's really frustrating. The drug was working, they stop it, and now you're in a position of having to either say, start the same drug or go to a non-preferred drug that's much more expensive. So we decided that ultimately we just, most of the states are going the way of not requiring sobriety, partly because it sounds discriminatory, but also you don't have the patient in front of you. You want the doctor or the nurse practitioner to feel, or the PA or whoever's prescribing, to feel at liberty to choose to treat their patient if they feel it's appropriate at the time, and not feel like they're going to be scrutinized for that. So those are the 2 major changes. We also shortened the algorithms to try and make them easier to follow. So I think our most of our PA criteria is just recommendations over what we consider the cheapest therapies, which you always seem to hit upon. And so our criteria is now a brief 5 pages instead of 9 pages. So anyway, those are the major changes here, just the wording stuff. But anyway.
Wow. Yeah, Brian, this is John here. I just will state it loud and clear for everyone to listen. I commend your leadership there. And honestly, Medicaid is always, that West Virginia Medicaid has been awesome from the start. So I appreciate you. By the way, that state of HepC grade, I bet it's going to be an A now. If you look at that, I bet you.
Thank you. The other thing I'm kind of working on the side is I've been attempting to engage with public health. I'm still working on that. But trying to get some diagnosis screening data, because my theory is that we probably cover 80% of the people who get HepC in the state of West Virginia. And so we're the major payer, and we should be engaged, I think, in trying to get the news out. The criteria is easier to get through, trying to connect people to therapy. I'd like to try and lead on that. But in any case, our ability to identify untreated patients who have a diagnosis of HepC is very limited, because we only see the people who have actually gone to a doctor, gotten a charged visit. We're not seeing the people who don't have regular office visits, who may have gotten to maybe they through some sort of screening program or something, they were identified as having an infection. A number I had heard was there was like 3,000 new infections last year. We have in our entire database only 1,200 patients who have a diagnosis of HepC. And you may have received a letter, from us, our retrospective DUR program. One of the things the major thing that we do with retrospective DUR is to identify drug disease contraindications or relative contraindications. But we also try and do educational interventions where, and one of those was to contact providers who were seeing patients who we saw a diagnosis for HepC, but no evidence of ever being treated with a DAA. And so we sent out letters for that, but we would like to have a better way of connecting these people. It's not that we want to, force providers into treating somebody they don't think is ready, but we want them to feel that they have a partner in Medicaid and we're willing to pay for it if they're ready to treat.
Man, that's awesome. Commend you for your leadership there. That's just, progressive thinking, and there's always that tie-in with any infectious syndrome with therapy to the individual does have societal wide implications, because these are communicable diseases. And I think it's very forward thinking and great that the primary payer in the state is going that direction. I'll try to get the word out too.
All right, cool. Thanks.
Well, Mitra, while we're waiting for Dr. Feinberg, I read a really cool thing the other day. If anyone has any, we don't have any other thing. She's not on yet, right? No.
She's not on yet. I emailed her too. So I think she's on the road. So we'll play, but we can keep it as an open discussion.
Yeah,
so absolutely.
Just with what Brian was talking about, we've had these drugs out since 2015. And I read a cool article the other day that we need to, as a country, treat about 260,000 people a year with hepatitis C to get it to go away by the end of the decade. So technically you could treat yourself out of the epidemic. This was some mathematical models. Right now, we're not even halfway there. So at a countrywide basis, we're treating about 120,000 a year. And the bummer that was, and this was data from the CDC that they talked, this was published in November at the AASLD meeting. They said that actually overall at a country level, we're seeing fewer prescriptions in over time as opposed to more, which kind of blew me away. So 2015 and 16 were the peak, and then it's decreased over time. I don't know that we're seeing that trend here in West Virginia, but at least across our country, that's a truism. And it's concerning because the opioid epidemic is winning. The more new infections, it's over treatments. And so overall, if you do look at the incidences, despite the fact that we have these beautiful curative therapies, the numbers are still climbing. So super bummer from that perspective. But I found it fascinating. By the way, I don't know why 2015 and 16 were such high prescribing years. I think it might have been before there was a lot of restrictions, period. I know when these first drugs first came out, there were no restrictions on them. We'd write for them, and when Maverick and sofosbuvir were our only options, and we could get them. But then, of course, I think the necessary restrictions that came on up front because of the cost and the triage for those who needed it the most. But anyway, I welcome any comments or.
I would John, I would probably say a big reason for that, since I was here, I actually started in Medicaid 8 years ago, and about 7 years ago, I think, or 6 years, it's probably 7 was when those first started coming out. And I remember they came out, we, all 50 states go to this American Drug Utilization Review Society conference in Arizona. And we had a speaker about talking about the new drugs and about how effective they were, but also about the cost. And so they advised, they've got the entire nation of Medicaid directors there advising restrictions on fibrosis score, pointing out it's a slow acting disease, that if we were too liberal up front, the drug costs would never come down. And so really they had recommended prioritizing and triaging patients, and so I think that's probably what happens. You didn't have criteria initially when they got approved, but as soon as people saw that, everybody kind of got the same criteria, started with F4 and then people started reducing it to F3 and then F2 and then nothing. So that might explain why you saw sort of open access initially and then a delayed response as people were advised by a common expert in the field on how to manage these drugs. And that's probably something you'll see on other drugs too, because as pharmacists, we understand the clinical use of the drugs, but we're also not trained as financial people, and so you kind of have to look for advice from people like ICER. ICER is one of the big. They're gaining a lot of power in the field of governmental policy and things, because they do very good in-depth clinical analysis of the benefits of drugs and what they think the cost should be to really meet the thresholds that they establish. So that's just my 2 cents on it, why you saw that perhaps.
Fascinating. Yeah, I think you're right. The data from the CDC that showed this decline year to year didn't include the last 2 years. So and that's honestly the last 2 years when I think most of the restrictions have fallen away. I know the West Virginia Medicaid got much more liberal in 2019 from a prescribing standpoint. So maybe we're going to see an upswing again. So again, and all you participating in programs like this, this is our goal to get this disease to turn the corner and at a public health level, decrease the transmission by using treatment. So, but thanks, Brian. Awesome insight.
Oh, you're welcome. And for anybody that doesn't know what ICER is, let me make sure I get the acronym right. It's let me pull it up here. The Institute for Clinical and Economic Review. So they're like an independent organization, but they do really high quality, really in-depth reviews of different disease states. So like, for example, they've looked at Alzheimer's, at COVID, at hemophilia, obesity, the beta thalassemia, ALS. So they do all this stuff and they look at the various guidelines and the various therapies out there, and they basically they advise, and they might publish like 100-page document or 200-page document, but they'll have a summary saying which drugs they think are cost effective, and which drugs they think are good if they hit certain, if the price was X. And almost always, of course, as expected, manufacturers are charging 10, 20 times more than what these guys think they should be charging. But, a drug like Apretude, they hopped on that they realized that's a game changer. So they are pretty fair, and I would, if you're not familiar with them, they are definitely an organization kind of keep an eye on, because they do have a lot of influence, and I think they're growing. Their influence is growing quite a bit.
Thank you so much, Brian, for all this wonderful information. If there's any resources or anything you want to send my way, I'm happy to include it in the recap as well. And that link you chatted in, I'll certainly add that in the recap email. So I don't believe Dr. Feinberg, unfortunately, will be able to join us today. So I hope she's traveling safely. That's all that really matters. So we'll make sure to reach out to her, and maybe we can reschedule her didactic for sometime in the second half of the year. But we still have about 20 more minutes. So if there are any discussion things that you all want to talk about, I mean, this has already been such a great conversation, but yeah, we can keep it as an open forum if there's anything else anyone wants to discuss. I'll do the classic echo pause here and wait to see if anyone unmutes. And Brian, thank you again. I'm getting those chats in, so I'm going to make sure to keep track of all of those links and add them in the recap.
Sure, anytime. And anybody on the call, you can always reach out to us through me, through Medicaid, and we're happy to work with you to try and clarify. I realize our criteria is not always as easy to understand when you're not part of the development of it. Everybody reads things differently, and there's 7 of us up here right now and making policy for 600-something thousand individuals. So we're not able to take all clinical cases and all variations and people into all these things into consideration. So that's why we always have an appeal process. If you have something we didn't think about or something we were short-sighted on, just let us know.
And no, we really appreciate that. The work you're doing is really difficult. I can only imagine. So we appreciate that. And it's so nice having you on the sessions as well to keep us up to date on all those types of things.
Thank you.
All righty. Well, thank you to our case presenters, Dr. Rexroad, Gary. We really appreciate you guys as always. And thank you all as well for always joining these sessions. It really makes it so wonderful having you all join and kind of chime in and give your perspectives and stuff too. So thank you all so much for joining. The only announcement that I have is that our next session will be on June 23rd, and Jean Pernell will be discussing alcoholic hepatitis and cirrhosis. So that sounds super interesting. Keep an eye out for that reminder, and we hope to see you all again next time. Thanks, everyone. Take care.
Have a great weekend.